BVF.
Okay, perfect. We'll start.
Yeah, just maybe introduce yourselves. Okay.
And this is Victoria. And we have another group member named Lisa Robson, but she's actually working at sick today. We're all nurses that work on the either cardiology floor or the CCU. And we're here to present today on atrial septal defects. We have no conflicts of interest to disclose. So today we're going to cover the anatomy and pathophysiology of the ASD, the clinical presentation, the manifestations, the medical and surgical management, as well as complications. So we're just going to start off with a quick little video, just kind of explaining ASD. Bear with me while I try and solve this.
Inside the heart is a wall called the septum. It separates blood coming from the lungs and blood going to the lungs. An atrial septal defect is a hole in the upper part of the septum. Some blood coming from the lungs gets through this hole. When this happens, too much blood goes to the lungs. In a normal heart, there is no hole in the septum. All blood coming from the lungs goes to the body.
You might need to come a bit closer to the mic. I'm just having a bit trouble hearing here.
That's okay. Can you hear us better from here, Cecilia?
Yeah.
Awesome. So on the left-hand side, there's a diagram. It has 4 pictures. So we're just going to talk about a couple of the ASDs that you'll see in the picture. So atrial the initial separating the
I can't hear, sorry, there's lots of feedback there.
Cecilia, can you turn off your mic maybe?
My mic is off here. Let me just check the other side.
Thank you.
Try now.
So the initial structure responsible for separating the left and right atria is called the septum primum, and then atrial septation is completed by an atrial wall growth to the right of the initial septum, called the septum secundum. So there's 3 types of defects that we'll touch base on, and then 2 more that aren't in the picture. So the ostium secundum is located in the center of the atrial septum and is the most common type of ASD that we'll see. The ostium primum is located near the lower portion of the atrial septum and may be associated with defects in the mitral and tricuspid valve, which is the second most common type of ASD that we'll see. And the sinus venosus is located near the top of the atrial septum and is frequently associated with abnormal connection of the right pulmonary veins to the right atrium instead of the left atrium, the least common type that we'll see. 2 ASDs that we don't see in the picture involve the coronary sinus defect, which is failure of the formation of the common wall separating the left atrium from the coronary sinus, and the PFO, or the patent foramen ovale, which is inadequate fusion of the septum primum and secundum. So just the usual ASD clinical presentation. ASDs actually make up about 6 to 10% of all heart abnormalities and occur in about 1 child in every 1,500. They're usually asymptomatic depending on the size of the defect and the ventricle compliance that goes with it. There's typically a left to right shunt. Higher saturations are in the right atrium than the SCC and IVC due to the shunting. The right atrium and right ventricle are often overloaded. You'll see shortness of breath, fatigue, and they could go undiagnosed until adulthood. Those kind of things you'll see from that is intolerance to exercise, arrhythmias, palpitations, and increased incidence of respiratory infections. The right side of the heart is very compliant, so there is that left to right shunt across the ASD, which can result in RV dilation. As a result, RA fibrosis can occur and act as a substrate for the late occurring atrial arrhythmias. RV dilation can also result in tricuspid insufficiency due to tricuspidal annular dilation. With a large ASD, the shunting can result in pulmonary congestion, and while unlikely, can also result in pulmonary hypertension. Due to some of the mixing of red and blue blood through the shunt, often oxygen saturations are greater than 88%, which will be deemed acceptable by the medical team. which can also explain why some patients may have persistent dyspnea and fatigue.
So the two ways that you can often find an ASD is through an echo. So you'll see in the bottom right picture where the right arrow is pointing that you can see a hole in the septum between the right and left atria, or an audible murmur that can be found around the second intercostal space, which is created due to a delay in the closure of the pulmonary valve because there's more volume of blood on the right side of the heart.
And we just actually have a quick video to show you guys of what it sounds like. Again, bear with me. Perfect. So we hope that gives you guys something just so that you can start listening to when you're doing your assessments. So the medical management that we often see is the use of diuretics. They're used for symptom management and with helping to kind of combat that increased work of breathing you can see in ASDs. Often they would be ordered 1 milligram per kilogram of Lasix. Usually it can be ordered either daily, BID, or TID. In our practices at SickKids, you can see often a lot of our kiddos kind of need multiple different types of diuretics to kind of combat any kind of increased work of breathing or fluid overload.
In order to treat an ASD, we have two options, which is surgery or device closure. So small ASDs where the QP to QS is less than 1.5 to 1 often doesn't require any surgery. And in about 40% of all cases, the hole will close on its own by the age of 2. If the medical team needs to surgically close the ASD, it's done either through a sternotomy or a thoracotomy with a direct suture anastomosis or patch closure, which you'll see in the first picture, the little pink circle is then closing the ASD. But the majority of ASDs are actually able to be closed in the cardiac catheterization lab using an ASD device closure. So in figure 2, it shows two different types of closure devices that you might see. And this is the preferred method because obviously if you can avoid cracking someone's chest for open heart surgery, you would prefer to do that. It requires careful echo evaluation at the time of closure to determine the rims of the defect, as well as balloon sizing of the defect to determine the proper size and type of device to use to close it. And with the device closure procedure, if you look at the figure on the right-hand side, it kind of explains how they deploy that device. So the left atrial portion of the device is delivered and pulled back against the atrial septum. Then the right atrial portion is delivered, and then correct device placement is confirmed by fluoroscopy and echo prior to the device release. And over time, tissues will grow over the device.
So the complications that we can see, to be honest with you, really in infants and children, we don't see many complications. However, if the ASD was unrepaired and found in adulthood, there's a higher likelihood to see things such as arrhythmias, really coming from the atrium, atrial kind of factor, stroke, right heart failure, pulmonary hypertension, and even effects on how well the heart can pump blood. As kids get older with ASDs, there might be an increased risk for stroke because a blood clot could form, pass through the hole in the septum, and travel to the brain, as well as pulmonary hypertension, really those high pressures in the lungs, also may develop over time in older patients with larger untreated ASDs. Device migration is always a possibility. As with any kind of catheterization procedure, there's always a risk of contrast reactions, vessel or cardiac perforation, and the introduction of infection. These can all lead to possibilities of kind of more surgical interventions or medical management kind of going forwards. So the complications and future considerations that we thought of was that medications to kind of prevent blood clots and infections are usually typically used in the first few months after ASD closure. It is uncommon to see kind of long-term medication use in this population. For children in particular, long-term complications are quite uncommon. They're often followed by a cardiologist for the majority of their lives. And after those kind of initial healings, especially here at SickKids, we kind of have great restrictions on our children to undergo cardiac surgery for about the first 6 to 12 weeks of their post-surgery. But once that's kind of done, there's no really activity restrictions that are needed. Studies and cases that we've seen have indicated that children diagnosed with ASDs and unrepaired in childhood expect to live long and normal lives similar to their peers. There's a small risk of blood clots forming on that closure device where the new tissue heals over it. So kids who've had a catheterization take low-dose aspirin for 6 months after the procedure. For 6 months following catheterization or surgical closure of ASDs, antibiotics are recommended before routine dental work or any kind of like surgery in general, just to prevent infective endocarditis. When the heart tissue is healed over that closed ASD, most patients no longer need to worry about the risk of infective endocarditis.
Right. We put this slide in because sometimes kiddos are born with an ASD that we want to close, and other times we'll actually make the ASD larger if they need it, or go in and create an ASD on our own. So a time where you might see that an ASD is made larger is in your single ventricle population, because single ventricle patients rely on interatrial communication in order to ensure that oxygenated blood is delivered both systemically and to prevent pulmonary congestion. So you'll see in the picture on the left that they actually went in and made the ASD bigger. And other times with your kiddos who have like a DTGA with an intact ventricular septum, we'll actually go in and do a BAS where we'll create an ASD on our own. And the creation of the ASD improves all mixing of saturated and desaturated blood, which is life-saving for infants with severe hypoxemia due to a restrictive atrial septum.
So Victoria, Lisa, and myself were trying to like kind of rack our brains around what could be an interesting case that we've seen at SickKids where we might create an ASD. So we came across one of our patients who was a 15-year-old female, previously healthy with a history of anxiety. She collapsed on a walk with her family. She was actually eventually through different kinds of imaging and echoes and chest x-rays diagnosed with severe pulmonary hypertension. So we brought her to the cath lab, and we found that her pulmonary hypertension was unresponsive to sildenafil oxygen nitric oxide, which actually led the team to creating an ASD to try to help relieve those pressures. But that put her at such a high risk for having TIs and stroke because of that increased pressure still being high and now having that ability to shunt across and go to the brain. So just kind of interesting how solving one problem can actually create different kind of things we need to think about going forward. So we have a bit of a test your knowledge section. So if anyone is willing to kind of participate, or Cecilia, if you don't mind, if someone mentions something in the chat, letting us know, that'd be great.
All right, so first question is true or false? ASDs are characterized by a hole in the interatrial septum, which allows blood to mix in the left and right atria, which are the lower chambers of the heart. And I don't think can access
we can't see the chat if anyone's
True.
sorry. So feel free to turn on your mic if you'd like.
False, it's the upper chambers.
Perfect. We really thought you guys were going to get you guys on that one.
இவளை விட 10 நாளா 20 நாளா சரி.
Yeah, so the correct answer is false. So our second question is, which structure below allows blood to flow from the right to left atrium in utero and should close after birth? So the ductus arteriosus, the foramen alveoli, the ductus venosus, or the ligamentum teres? Anyone have any ideas?
B.
B.
Great job, guys. I'm so happy you're paying attention.
Final question is a little NCLEX style. So the final question is NCLEX style for those of us who had to write the NCLEX many years ago. So a patient is diagnosed with a large atrial septal defect, and you're providing information to the patient on the complications regarding this condition. What topics will you include in the patient's education? Select all that apply. So A, TET spells, B, heart failure, C, stroke, D, pulmonary hypertension, or E, rheumatic fever.
This one's a bit trickier.
Stroke.
Yep, perfect.
Pulmonary hypertension,
Yeah,
Amazing.
and one more.
heart failure.
Amazing. Good job.
Awesome, guys. And that kind of leads to the end of our presentation. We do have quite a few citations that we use that we'd like to thank for everything. Hope you guys enjoyed it, and thanks so much for listening and paying attention.
Yay, great job.
Thank you, Cecilia.
Okay, can you hear me now? Yes, okay. So yes, that was an excellent presentation, another excellent presentation. I like how you used a few videos and incorporated some of the information from previous lectures, as did the last presentation as well. So including things like heart sounds and nice diagrams and echo. And I like the last test piece as well. Does anyone have any questions for Victoria or Jessica?
Not really a question, but I have seen where they put the device in and it flew off. So they had to go and have open heart surgery to remove the device and do the closure.
That's a very bad complication.
Yes. So I guess the family, it was really difficult because they were in just for a cardiac cath, and then the child went for open heart surgery.
Yeah, and where did it go? It ended up in the
Actually,
left.
I don't remember where it went actually, but
But they had to go and fish it out.
they had to take it out and do a patch closure.
Yeah. Oh dear.
Yeah.
No, it's great. Anybody else have any example? That's a great example of some of the complications that can happen from cath procedures.
Yeah, and also I like how they mentioned how they make the ASD for different defects. And usually at CHIO, they do that. The patient will be in the NICU and they take them or they actually do it at the bedside in the NICU. The interventional cardiologist does it.
Wow.
Anyway,
Yeah, no, great example.
but I have to also say that I loved all the videos and the pictures and the questions as well. Great presentation.
Yeah. Okay, so the next one is on VSD. So I'm not sure whether, because we're again a little bit early, so I'm not sure whether Sarah and Lindaway, Nicole, Duan, or Prathista are ready at this point. If they are, then we can go ahead. Otherwise, we can take just about a 15-minute break till 10.
We are ready if everyone else is.
Okay, great. All right, so you can go ahead then. I'm just going to press record too, once you're ready.
Okay, I'm just going to share it. Okay, so we have done